So just a few more cardiac things I wanted to touch base on. Just to remind you, the final exam will probably be about 80% new information and 20% things from the first exam that I wanted to make sure that people had gone back and figured out if there were issues. I'll definitely give you a heads up on the topics that are more likely to be included. But before we start, let's talk a little bit. Let's check in. I just wanted to touch base because very frequently students at this point either feel very overwhelmed if I've given them lots and lots of information, or alternatively, if I have tried not to overwhelm them, they sometimes feel like they haven't learned enough. The challenge is that most people can only learn about 6 or 8 concepts a week. No matter how hard we try, giving you 12 or 15 actually results in less learning. So I tend to believe that less is more. I think that there is real value to taking your time and thinking about things and really getting the concepts down rather than flying through hundreds of different things. There's a reason that your program's 2 years long. You don't need to know absolutely everything by the end of the semester. This is intended to be an introductory course. And again, don't forget that probably the most important skill that you can develop is how to think through the issues. Where do I go to get the information? How do I synthesize that information? How do I think about the things that I need to think about? So you kind of have to trust us. We'll get you to where you need to be. Don't panic. But I understand that it is a very stressful transition, both to graduate school and to a new role and lots of things. But be patient with yourself and be patient with us. So let's talk a little about atrial fibrillation. AFib is increasing in frequency as the population ages. There's going to be more and more people with AFib. It's not a horrible diagnosis to have. Most people do very well. It's basically, the heart's quivering a little bit in the atria. The ventricles are still working just fine, but you lose that atrial kick. So you lose about 10% off of your sort of ejection fraction. It decreases the filling and so decreases the output. Most people can tolerate that just fine. Nobody's going to die from AFib. They may die from the complications of AFib, getting a blood clot in that left atrial appendage and then having it break off and go to the brain. But the AFib itself is not a lethal dysrhythmia. It's an interesting question. We sometimes try really, really hard to get people out of AFib. If you have a young person, they're having symptoms because they've lost that 10% atrial kick, it may be worthwhile. An older person or anybody that's been in AFib for an extended period of time, there is not really a whole lot of value to trying to get them out. You're not going to be successful. They're going to go in and out at times when you don't know they're going in and out. Basically, no matter what, they need to be on anticoagulation. We used to think that if we got them out, we could take them off anticoagulation. We now know that's not true. And the AFFIRM study really did suggest that the outcomes for people that are doing rate control and the people that are doing rhythm control are basically the same. So nobody's going to live any longer if you get them back into sinus rhythm. So atrial fibrillation, we've all seen atrial fibrillation a number of times. Basically, there is no P wave that correlates to the QRS complex. There's that stuttery area, and there's irregularity. You can see that the distance between these R waves are substantially different. That's the biggest thing you'll see in a difference between artifact. With artifact, you're not going to have an irregular heartbeat like that has different intervals between your R waves. So there's a number of tachyarrhythmias. Again, you'll learn more about these as you go on, but two of the common ones are Wolff-Parkinson-White and Lone-Ganong-Levine. Both of these are associated with short PR syndrome. So if you have somebody with a short PR, you may need to get additional evaluation to see if they have evidence of WPW or LGL. But these are really conditions that if you do detect them, you're going to refer them to a cardiologist, and then they're going to actually determine the actual treatments. Long QT is something we need to be very aware about. Unfortunately, people with long QT can have sudden death. There's a number of different medications that are associated with long QT. There's a bunch of websites that you can check and see. But if you have somebody that's on a couple of different medicines that cause long QT, quinolones are famous for it, and certain anti-dysrhythmia medicines like amiodarone, those kinds of things, combinations of those can really result in really big problems. Many times long QT is genetic, it runs in families, but there can also be other electrolyte issues that make it a little bit more likely, or heart damage, or as previously mentioned, medications. So aortic stenosis. So aortic stenosis is a relatively not uncommon phenomenon where the aortic valve narrows substantially. The normal area of that valve is 3.5 to 4 centimeters squared. If it gets down below 1 centimeter squared, we talk about it being critical aortic stenosis. Most of those people need some kind of an intervention. Often surgery. We now have the ability to do a transvenous or vascular aortic valve replacement. And it is pretty amazing, actually, that we can pass it through, and then it basically just inflates, pushes the bad valve out of the way, and takes over for it. Right now, we're not doing them all that much. They're relatively new. I think we're going to be doing them more as time goes on. Now, one of the things you'll find on a echo report that's fairly often is they'll note that the patient has a bicuspid aortic valve. Normally, the aortic valve is tricuspid. We know that people that have bicuspid aortic valves are a bit more likely to have valvular problems later on, to develop stenosis. And so there is value to sort of monitoring them with interval echoes. I have cardiologists that I know that check it every year or two, others that check it every 5, depending on the patient's age, depending on other variables. But at any rate, if you do see that someone has a bicuspid aortic valve, we are going to need to monitor that. They often do have a murmur. I did want to just mention the fact that for most of us, if the patient has a murmur, we're going to go ahead and get an echo. Some people try to spend a lot of time figuring out where, the aortic valve, you're going to hear at the base of the heart, you're going to hear it on the left, you're going to hear it on the right. Again, I'm not sure that it's that critical to know that. If you hear a murmur, you're probably going to want to actually get an echo, just because it doesn't always correlate to that location on the chest. But cardiologists often do pay attention to that. Some providers do get very savvy. Others don't spend a lot of time thinking about it. Mitral regurgitation is not super common. It is associated with rheumatic heart disease. Those folks often have had strep throats and may have had under-treatment, non-treatment. People that are fully treated still sometimes develop rheumatic heart disease. It does decrease the probability some, but it doesn't eliminate the possibility. So just something that you do need to be aware of, just because people will say, why do I need to get my strep throat treated? Well, the reason is because that bacteria can lodge on that mitral valve, cause damage, and then people will have substantial regurgitation later on in life. So stress tests. I'm not going to spend a lot of time talking about that because it's more of a clinical issue. But I did just want to throw out the fact that a lot of people think that anybody with chest pain needs a stress test, and if the stress test is okay, they're okay. It does decrease the probability that they're going to have a fatal heart attack, but not by much. There is a mild benefit. You do need to have at least a 70% blockage, so that if you threw an embolus from somewhere else and it blocked one of your coronary arteries, you could have had a completely normal stress test a month ago, and then block off your left, your left main, have that widowmaker, and die. There is the article from the emergency journal there, EP Monthly, really does have a good discussion. Again, stents may not really save lives to speak of either. Science Daily suggests that there really is no benefit to doing a stent as far as life-saving. Often there is benefit as far as quality of life. People do feel better. The exception to that is if somebody's having a STEMI, there's about a 17% decrease in the death rate, but it's not 100%. It's not like if you do the stent, they'll live, and if you don't do the stent, they'll die. And in fact, some people do have complications from the stents. And again, it's even more complicated if you've got an N-STEMI or unstable angina. There does seem to be some evidence that there's less MIs, but there's also some evidence of procedure-related MIs. So it's not black and white. It's a tough clinical decision to make. There is an app that you can get. It's the Multimodal Appropriate Use Criteria app, and it will help you walk through the process of trying to decide what stress test to do. There's a lot to know. Basically, a lot of us know very little about cardiology. Some of us know a lot. And it is going to very much depend on if you end up doing mostly kids or doing mostly women's health or whatever. Your level of knowledge is going to be different than somebody that's doing inpatient or doing a lot of cardiology type things. It's great that we have those more specialized people available to help us, but figure out how much you need to know. And for the purpose of this course, again, this is a introductory survey type course. Just try to hit the highlights.